Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Ford, and I'm the chair and organizer of Grand Rounds. One of the deals I made with Professor Hothersall Davis last year was that the medical school would take the first slot of every month, and we would do something along the scholarship lines, and it's been a great success. For me, I get to fill a slot once a month, which is a great bonus. But we've been able to hear from many of the sort of unsung heroes, the people behind the scenes of the medical school, and particularly in the Centre for Medical Education. And that theme continues, and hopefully continues into 2026. So today, Sam Smith is going to speak to us about transformative simulation. If you were at the Ronald Harden lecture in the Wolfson or online just last month, you'll have heard Jen Cleland speak about simulation and its value. And she means that I was talking in terms of monetary value because her talk was about money, money, money. I think we're going to hear today about the value of simulation for our students and for us and for our patients ultimately. And Sam's going to talk about that. So, usual Zoom rules apply. Do please mute your microphone if you're not speaking. Feel free to leave your camera on if you'd like, although I'll turn mine off because no one wants to see me eat some spaghetti whilst you're listening to a talk. Questions in the chat if you wish, or you can use your real life voice at the end. Thanks very much, Sam, for joining us today, and looking forward to hearing your talk.
Thanks so much, Tom. I'm Sam Smith. I am a clinical senior lecturer at the Centre for Medical Education, and I'm a GP by background. I'm going to talk today about some work that I did when I was working at the Scottish Centre for Simulation and Clinical Human Factors. So I know there's an awful lot of great work going on in this transformative simulation space in Tayside as well. And I'm sorry that I didn't get a chance to hook this talk up and talk with people who are doing that work here. I will put their contacts up at the end, and perhaps we can have a follow-up grand round in the future, which looks at the transformative sim that's going on in Tayside. But for today, I'm going to talk about some work that has been happening in Forth Valley. I wanted to start with something Christmassy. So I'm starting this story in Bermuda in the year 2017, pre-children, pre-pandemic, when I was living in Bermuda and I was having Christmas on the beach trying to make a snowman out of sand. And I had no idea at this point what transformative simulation was or how much it was going to influence my career and the work that I would do from there on in. So fast forward 4 years, and I was coming back from Bermuda, and I was very lucky because my long-term research partner, Vicky Talentire, was going off on maternity leave and had left a gap in research at the Scottish Centre for Simulation and Clinical Human Factors at Forth Valley Royal. So I was able to step into her shoes for a little while, and it's there that I learned all about transformative simulation and really became passionate about this and why it's so interesting. So this slide is from the work of Sharon Weldon, who is a professor in simulation at the University of Greenwich. And she's done a lot of work on the conceptualization of transformative simulation and what it is. And she talks about how simulation doesn't have to just be used for education. We all think about educational sim. We think about the sim we use to educate our students or our trainees. We think about sim for assessment, like advanced life support courses. But we think less often about simulation for innovation, improvement, intervention, involvement, identification, inclusion, and influence. And this is the kind of simulation that I'm going to talk about today. So not simulation as part of education, even though I'm in the education slot of Grand Round, so sorry about that. But we're going to be talking about simulation for improving patient care and improving healthcare professionals' well-being. I'm going to give you a couple of examples to make these kind of nebulous concepts a little bit more tangible. So the first example I'm going to give is about GP in situ simulation. And this is an example of transformative simulation in the identification space. It's using simulation to test systems. So, in situ simulations, by definition, are those that occur in the actual clinical environment and whose participants are on duty clinical providers during their actual working day. It sounds logistically tricky, and it is. There are a lot of last minute cancellations with this kind of simulation because life and real work gets in the way. But when you consider the importance of this sim and what it can do, then hopefully you can see how you could try and carve out a little bit of time for doing these things that can make all of our processes more efficient. And this has been done in hospital wards as well, not just in GP practices. So the purpose of in situ simulation is to improve an individual's technical proficiency, of course, but also to reinforce desirable team behaviours and to identify active and latent systems issues which can bring about change in clinical care systems. And all of these, of course, are intended ultimately to improve patient outcomes, which is the gold standard, the thing we're always trying to do. And so when I was asked to run some GP in situ simulations, I thought that that was going to be all about reinforcing desirable team behaviours, because I thought that the benefit of running an in situ simulation was that you could get that actual team that worked together all the time. You could get them in a sim together because you're going out to them instead of asking them all to give up their workday and come to you. And so I designed a sim that went something like this. I would go out to a GP practice and I would involve absolutely everybody in the practice team. So that would involve receptionists, physiotherapists, GPs, advanced nurse practitioners, practice nurses, GP trainees, administrative staff, pharmacists, anyone who was attached to the practice was welcome to come along to these sessions. And I had sessions in Drimmen with 4 people, and then I think this was my largest one. I don't know how many people are in this room, but it was a lot. And we do a pre-briefing where we talk about simulation and what it is and what the purpose of the sim is. And I would let them know what the scenario was going to be. And that scenario would be most commonly either acute seizure or cardiac sounding chest pain or meningococcal sepsis, something that tested a bunch of different systems within the GP practice and allowed the team to really show their behaviours, such as communication or situation awareness, or the different team working behaviours that they could have. So once I'd explained what the scenario was going to be, I'd ask for a few volunteers, maybe 4 or 5 people who were going to get involved in the actual sim. And I would have one of the fellows, or occasionally somebody from the practice, or some very kind volunteers who came and did this out of the goodness of their hearts, who would come and be the patient, and we would run through the simulation. And that would involve, first presenting at the desk, or perhaps out in the car park, or complaining in the waiting room, and we would run the scenario from there. And the team would have to react by using the equipment and drugs that they had there in the surgery. So if, for example, you had somebody with chest pain and you wanted to give them morphine, well, you'd have to go and get the vial of morphine and sign it out of the cupboard. And you'd also need an antiemetic if you were going to give one, but you'd also need to bring needles to draw it up, needles to administer it, and syringes and gloves. Everything that you wanted to administer that drug, you would need to bring with you to the patient, and then we would consider it given. I wouldn't ever ask anybody to actually open drugs and pretend to administer them because of safety risks and also just waste. But the same applied for equipment. If they wanted to give oxygen, they would bring the oxygen tank, but also a mask that fit and the tubing to connect it to the oxygen tank and make sure that they were able to switch the oxygen on and off. So we made it as realistic as possible using the actual equipment they were going to use, using teams that were a kind of realistic mix of skills, like a practice nurse and a GP and a trainee and a receptionist. It would be an example of a team that might be trying to deal with an emergency. And sometimes we allowed those emergencies to take place in the consultation rooms, But more often than not, we made them somewhere really awkward, like out in the car park or at the side of the building. Those are always the most difficult GP emergencies to deal with, or the person who's collapsed at the bus stop, or in the middle of the waiting room if we were able to close the practice at lunchtime. And then we would have a debrief where we'd talk about what went well and what was challenging and try and reinforce some of those good team behaviours that I was talking about before. And I thought this was a really great sim, and we did enjoy running these sims. But they were really, the design of the sim was to test desirable team behaviors. And over again, we saw that these teams had great team behaviors. These were people who had not just been working together for a few years, but often for decades. The communication between them was excellent, and there was really little to say in terms of improving their team behaviors other than, well done, that was great, you should do that again. The things that tripped them up were not the team behaviors, it was the systems issues. There's all kinds of problems within a GP practice with regards to the system and the way it works. And it was those systems issues that were causing the problems. So we had to redesign the sim. We had to think beyond an educational sim to a transformative sim, a sim that was going to test the systems. And to do that, we made three big changes to the way that we ran the sim. And these are things that you could do in your own clinical workplace. Very simple, low resource simulations and easy changes that you could make. So the first change that we made is that we incorporated something called process mapping, which is from the engineering field. Engineers are very keen on process mapping. They like efficiency. And in emergencies, efficiency is really important. So I think we should take a leaf out of the book of the engineers and take a look at this. We used a really simple form of process mapping where we created cards with different things that people might want to do in an emergency. So examples might be, oh, we'd want to insert an IV cannula, or we'd want to give oxygen. And I had blank cards so people could write their own things and they were allowed to amend the cards. And so I would say, today we're going to be simming an 18-year-old coming in with a fever and a headache and a purple rash, who's very unwell. And we would run through what would be the ideal way that people in the GP surgery would respond to that emergency. And we lay out the cards exactly, we'd want this to happen and this and this. And during that process mapping exercise, just on the tabletop, before we'd gone anywhere near any of the sim, all of these systems factors would come out like, oh, well, actually, the drugs are locked away in the cupboard, and the key to the cupboard is over there, and the emergency equipment is kept somewhere completely different. Maybe it would be helpful if the emergency drugs were just kept with the emergency equipment. So if we found something like that during the process mapping stage, we would change it. We'd change it before we even started the sim. We'd say, right, we're going to put everything together in one place. Sometimes we found things that you couldn't do during the sim, like, oh, it would be great if all the equipment was in a grab bag instead of locked in the cupboard. Well, we couldn't change that there and then, but we wrote it down. So we'd done the process mapping stage, and then we would run the sim as before, but our change number 2 was to the debriefing that we did afterwards. So this debriefing model is from the Scottish Centre for Simulation. This is the Scottish Centre debrief model, which is what we use for our educational sims. And if you've not seen this before, it's very similar to other debriefing models that are out there. But there's a reactions phase, which is all about the emotions of the sim, letting those emotions out. Ah, that was terrible. I can't believe I did that. All of that stuff. And then you have your agenda, which is what was good and what was challenging. And then you have an analysis of those factors, which is supposed to try and tease out the learning objectives of your educational sim. And it will result in some take-home messages that have come directly from the participants, which in an ideal world relate back perfectly to your learning objectives. But of course, in a systems testing sim, there are no learning objectives. You're not aiming to teach somebody something, you're aiming to test the system. So we needed to do a different kind of debriefing. So we kept that reactions phase and we kept that what was good and what was challenging. But then we look back at our process map and say, well, what did we hope would happen? And what did happen? And why didn't it happen exactly the way that we wanted it to? And if it didn't, what can we change in the environment that might make things better? And so we came out with a list of systems changes. And that leads me to change number 3, which is the outcome of the simulation. So instead of ending up with some educational take home messages that each person could take away and put into their own practice, we came up with a list of systems changes which would make that emergency and other emergencies like it easier to run in the future. And at the end, we would assign each of these systems changes to a person who was going to enact that change and a time scale and exactly what they were going to do. So we ran the educational sim 7 times, and then we ran the new systems testing sim 14 times. And we found that we were able to increase the mean number of systems changes that we identified. And even within this tiny sample, there was still a statistically significant change from a mean of 3.6 to a mean of 6.7 changes identified during the sim. And these are the sorts of things that the sorts of changes that we were identifying. Equipment changes were by far the most common. So practices would often commit to purchasing extra equipment or moving the equipment in particular. Adding protocols to the bag was a common one. So everybody thought that they knew in their heads the doses for everything, and everybody indeed did know off the top of their head the dose for anaphylaxis. But not everybody knew the dose for everything. And when you're flustered in an emergency, it's hard to remember. So having those emergency protocols, which are commonplace in hospital, added to the emergency bag was another. Changes to drugs were also important. So our seizure was one of the most common scenarios that we ran, and there had been a relatively recent change in protocol from rectal diazepam to buccal midazolam for seizures in the community, and that change had kind of not filtered its way down to the GP practices. So even just running that scenario made them, oh, we'll need to get some buccal midazolam and put it into the emergency bag. There were changes to standard operating procedures. So, for example, we found that maybe to our surprise, having a reception team member as part of the emergency team every time who went away and did something and then came back to the emergency was super helpful because they were able to go and get things, they were able to find out information about the patient, make phone calls, and then that freed up some of the clinical staff to keep seeing the patients that, of course, were still there when the emergency is running. And then there were also staff education changes, particularly teaching new staff about where the equipment was and making sure that, for example, all the clinical staff know how to use the blood glucose monitor, not only the practice nurse, as was the case in an awful lot of practices. So that's transformative sim for systems testing. And although the examples in GP, and I realise a lot of people here will not be working in that setting, I think you can possibly see how that might apply to a lot of different settings. So I'm going to switch gear now and talk a little bit about transformative simulation for influencing, and in particular for influencing social integration. So this is a passion project of mine. This is a piece of work we've been doing a few years on the topic of refugee doctors. We're now probably more commonly using the term displaced doctors, which I think is a bit more inclusive than refugee doctors, but I've been calling them refugee doctors for a long time, and indeed the charity calls them refugee doctors, so I will probably use those terms interchangeably as I talk here, but I'm talking about the same cohort of people who have had to leave their home countries due to circumstances beyond their control. And this is the piece of work that I'm going to be talking about. It's a paper that was published in Advances in Simulation last year on the topic of using simulation to influence workforce integration. This quote really sums up the whole topic for me. The great ages did not contain the best talent, they wasted less. And I think that wasted talent is probably the best way that you could describe the thousands of refugee doctors throughout the world that there are that are currently unemployed. And certainly there's a good cohort of those in Scotland just now. I want you to imagine for a moment that you are one such refugee doctor and you have had to leave your home due to war or persecution, and you arrive in a new country. You can't prove your qualifications because all of the paperwork is in a war-torn country back home. Your new country is different in terms of the language and the culture, and even the healthcare system is unfamiliar. You're coping with grief and trauma and all of that without your family around you. You have money worries, and as time goes on, the years pass, and you've got a bigger and bigger gap in your clinical training or clinical practice. And on top of that, if you manage to overcome all of those difficulties and you manage to take the language exams and the clinical exams for your new country, then you're more likely than doctors from the host country to be referred for remediation. And of course, that's exactly what we don't want to happen. So this is where the Bridges programme steps in. This is a charity in Glasgow which helps refugees to find work, and they have a particular Bridges Doctors programme helping doctors into the system in the NHS. And the Bridges programme's asked for help from the Scottish Centre for Simulation to develop a simulation programme which would help refugee doctors with workforce integration. This is the paper that describes the development of that simulation curriculum. This is by Julie Doherty, a lovely paper describing how that curriculum came to be. And some of you might be familiar with this curriculum because it actually informed the curriculum that IMG doctors in Tayside now go through when they first come into the NHS. This is the original version. I think IMG's induction is a slightly modified version of this. So day one is an introduction to simulation. Day two is an introduction to a systematic approach. So using A to E to assess a sick patient, or using ISPAR or SPAR to structure a handover. Day three is about multidisciplinary team working and explaining the roles of different members of the team. Day four is about decision making, such as DNA CPR decisions and adults with incapacity. And days 5 and 6 are a chance to bring all of that together and run some acute care scenarios. So the aim of my research was to explore how involvement in that sim programme influenced workforce integration for the refugee doctors joining the healthcare system in Scotland. And I asked for volunteers who had taken part in the simulation programme to take part in an interview study. And 14 people came forward. And we conducted some interviews based on an existing theory of workforce integration. This theory of workforce, so make it a bit bigger. This theory of workforce integration is based on an integrative literature review of refugee doctors' integration needs throughout the world. And what was fascinating to me doing this literature review was that the integration needs that you see were the same whether it was doctors moving from North Korea to South Korea, or from Cuba to Miami, or from Syria to Turkey. All of these different movements in totally culturally disparate places resulted in the same integration needs. The first category of needs was the foundations. So these are the rights and responsibilities, the things people really need to have before they can possibly integrate. And key to that is freedom from discrimination and exploitation. And then there's these three pillars that once you have the foundations in place, you can work on. And the first pillar is learning, all the things that refugee doctors need to learn before they can integrate. So they would need to learn the language, not just the basics of the language, but also the language that we use in the NHS. So all of these different little acronyms that you'll see in the notes, ATSP, asked to see patient, or BIBA, brought in by ambulance, any of these little acronyms that are hard to pick up, even moving from one part of the country to another, let alone moving from a whole different country in a totally different language. Then there are the cultural nuances. This is the fascinating bit for me. Things like the difference between pointing with one finger to chair, sit down, versus palm up, pointing to chair, sit down. The difference that can convey and how that might be perceived differently in different cultures. Or that a doctor from Iran told me that it would be considered terribly rude in her country to look somebody directly in the eye whilst delivering bad news. And of course, I think if you tried to deliver some bad news to somebody without looking them in the eye, they would be very offended and assume that you were trying to deceive them, I think. So these cultural nuances are really important to learn. They would often need to learn some clinical skills because doctors in other places don't always do IV cannulas or ECGs, so they may need to learn those skills before they could act in a doctor role in the UK. They would also need to learn about the hospital systems. So, for example, many places in the world don't have general practice. So, coming here, you have to learn about the difference between primary care and secondary care and how those two things interact. Then we have the connecting pillar. That's about social connections. So, social bonds are connections between people who are similar. Just for example, two IMGs. Social bridges are connections between people who are different. So, for example, a simulation participant and a faculty member. And we've also got social links, which are connections with organisations such as the Bridges programmes. And then finally, this is my favourite pillar, the pillar of being or identity work. And identity work is this concept that we all have multiple identities, and that those identities can change or shift over time, but that change requires explicit internal work. So to give you an example, my own identities, I am a doctor, but explicitly I'm a GP. I'm also a medical educationalist, and I'm a researcher, and I'm a medical education researcher, but I'm other things too. At home, I'm a wife and a mother, and elsewhere, I might talk about my love of skiing or jogging. So, depending on who I'm with and who I'm talking to, those different parts of my identity will come to the fore. And identity work was seen in all the refugee doctors in studies all over the world. So, how does this model, this idea of workforce integration, interact with simulation? Well, inspired by one of the refugee doctors, we conceptualized simulation as the building blocks for each of these pillars, and missed opportunities as missing blocks within the pillars. We could talk literally all day about this topic, but I'm going to keep to just that final pillar because I think it's probably the least obvious to understand how participating in a simulation might inform somebody's identity. So, in terms of professional identity, the simulation program provided an opportunity for participants to reclaim their identities as doctors through acting in the role of doctor and working with colleagues. It instilled participants with motivation and the confidence to reclaim the role. So you have to remember that some of these doctors have been out of work for 5 or 10 years. I think the average was about 8 years out of work. One of the doctors said, I got to touch a patient. I know it was a mannequin, but it was a talking mannequin and I could perform. I was using my skills after such a long time. Doctors also helped embrace a new social identity, and that was the identity as an international medical graduate or IMG doctor. And that was really facilitated through the social bonding that doctors went through during the simulation program. For revalidation or appraisal, we are different. We have a small group to ask some common questions, try to help each other. Involvement in simulation could also threaten identity. So one participant found that simulation exposed knowledge and skill gaps, which reduced confidence, but this was restored by the end of the program. In the first 2 or 3 sessions, I feel disappointed and depressed because I forgot a lot of critical things. 4 or 5 years away from clinic has a very deep impact on my esteem. So in summary then, simulation could help refugee doctors to reclaim their identities as doctors And it did this by helping them to learn skills which helped to re-establish them as credible experts. It helped by allowing them to introduce themselves as a doctor, just naming themselves as a doctor within a scenario was so important. But exposure of knowledge gaps could threaten identity. So we had to be really careful at the level at which we pitched the simulation, particularly at the beginning of the program. And to be honest, most of these simulations were pitched at the level of a final year medical student. The simulation also helped with claiming a new identity as an IMG doctor. We thought a lot about this and whether that's a negative or a positive. And there is some evidence to say that othering can create a reactive identity formation, but I don't think that's what's going on here. Through the interviews with the doctors and just my interactions with the other refugee doctors on the program, I think this is just an adaptation which allows refugee doctors to maintain their social and cultural identities while still integrating into this NHS in Scotland. Overall, the simulation was a vehicle for conferring expectations, not only expectations about the role, but also expectations about the culture. And there's this lovely concept of cultural compression, which is by a researcher in Australia called Eve Purdy. And she talks about how simulation can really magnify cultural differences and allow us to explore them and examine them in more detail. And we've really seen that in this program. We've seen how just these tiny body language gestures, ways of doing things get magnified within sim and how it allows us to try and sensitively address them. So this is a totally different kind of transformative simulation. In this simulation, we're trying to achieve social integration. And I wouldn't suggest for a moment that anybody should be trying to set up a sim with a sole purpose of trying to achieve social integration. But just to consider that even sometimes our educational sims can serve a greater purpose and can be doing more than we've asked of them. There's all kinds of other transformative sim going on. So Dan Houghton is lead for Transformative Sim in Forth Valley, and Julie Marden is the director of the Scottish Centre of Simulation. And they've been doing some work on trying to reduce the number of cardiac arrests in Forth Valley Royal. And I believe there will be a paper coming on that because they have achieved, through simulation, changes that have reduced the actual number of cardiac arrests. And there's a lot of work going on in Australia where they refer to this as translational sim, which I think is just another term for transformative sim. As I examine the way people talk about it, it seems to be the same thing. So this one, a simulation-informed biopsy of current systems challenges, or an outreach simulation for systems improvement. And there's just a really nice idea here of a really low-key, low-resource simulation that you could run on a ward. This is a sim by Ben Simon, who is a simulation enthusiast in Australia who writes a lot about simulation and transformative sim. And he talks about this sim which uses two dialysis bags to simulate the run through of a massive hemorrhage protocol, or major hemorrhage protocol as we would call it. So they put one bag on the top and one bag on the bottom, and they could control the flow out. And the team would have to, just using expired blood products from the blood bank to make it more realistic, run through the process of getting the blood from the blood bank to the patient, the bag on the bed, before the bag ran dry, or keeping a certain level within the bag. So you can see how even with really very, very little resource, you can create quite a realistic sim that gets everybody's heartbeats going on the wards. So my take-home message for you is that as a medical community, I think we should be curious about the potential of simulation experiences to reach beyond simple learning and to consider their power to transform healthcare. I have heaps of thank yous, so I'm just going to leave them up on the screen for a second. But I should also say that there is work going on in Tayside, and I think that we need to hear about that as well. And if you're interested in reaching out to those who are in Tayside, Then I've put up some of the email addresses here, Neil, Susan, or Jill in DIHS, who've been working on some transformative sim projects. Or of course, we've got Ashut and Babar on the IMG sim side doing lots of great work there as well. So I am by no means saying that this is my particular space to work in, just that I've enjoyed the experiences that I've had in it. And I hope that we'll be seeing lots more transformative sim in Tayside in the future. So I'm probably way short on time because I talked a bit too fast, but that's okay because then there's plenty of time for questions.
A wizard is never neither short of time nor over time. A wizard is always precisely on time. Well done. Thanks very much. So any questions from the audience? Do stick your hand up if you've got a question. Did you come to Jen Clellan's talk? Were you there,
I was
Sam?
there, yeah. I was
Yeah.
freezing there in the very,
That's
very
right. I remember
cold
it. It was
Wolverhampton.
very, very cold in the lecture theatre, wasn't it? For reasons unclear. Um, she did speak about simulation a little bit
Mhm.
in that talk, and sort of challenged us to see whether it is of value or not, and how to go, well, perhaps how to get the best value out of simulation. Do you have to do the whole shebang, or can it be in pockets? Did you have any reflections on that as an expert in the audience at the time?
Yeah, I think there's so many different ways of doing simulation, and that example I put up at the end. That I mean, the equipment that's required for that is really just stuff that's lying around that's gone out of date that can't be used for patients anymore. And certainly, the only resource that we used for the GP sim was my time. Really, there wasn't anything else apart from people did this in the lunch hour basically, and my time was paid for by a ring fenced pot of GP CPD money that they seem to have managed to keep aside in Forth Valley. All these NHS little secret pots of money that seem to exist in places. So yes, I think there's always going to be the resource is always going to be on the facilitation side because you probably can't just come in and run it. But probably most people could just come in and run it with a little bit of guidance, actually.
Question from Musa. Thank you, Sam, for your interesting talk and great work. Regarding your systems change project, I'm curious about how you managed to secure the necessary time and engage the team in such a project within a service-oriented setting. And then the other question is about the ultimate patient outcomes for the same project. Was there any evaluation conducted after implementing the system changes in practice?
Yes. Okay. So first question, engaging the team. Um, Not as hard as you think because most people are crying out for free education. And if because they do get education out of it, I think it would be a harder sell to say this, we're going to come and test your system. But if you say we're going to come and run a sim, we're going to practice doing some emergencies, most people quite like that, especially when it was at no cost to them. Getting the reception team engaged was an interesting exercise. I had people rushing out in tears before it even started, getting very, very anxious about it. So there was a lot of um, kind of foreshadowing at the beginning that you don't have to be involved and like you can just watch. It's fine. Nobody's going to force you to do anything. But yeah, getting the word out that usually when you get one or two practices involved who really like it, then they tell all their friends, and that's how you get that. That's how it kind of snowballed into more and more. So you just have to put a lot of effort into the first ones and make sure they're really good. Um, the second question, that's the dream project. There are problems with this project with looking for patient outcomes within my own setting in general practice because emergencies in general practice are thankfully extremely rare and disastrous emergencies with bad outcomes for patients are extremely rare. So I don't know how you would go about designing a study that actually showed an improvement in patient outcomes. I think we're always going to be looking at proxies. We can certainly do a study to go back and rerun the sim and see if the sim went any better the second time, or to see if the changes that people had committed to making had actually been made. that would be the next step, I think.
You say something interesting about engagement of people that sometimes you run these sorts of things and people think it's a test, that it's out to catch people out and you don't know the up-to-date guideline, you've done that wrong, you put that on backwards, you stood in the wrong place, you're done. But of course that's not the point at all. And it's like any like Christmas parlor games, you need to be encouraged to get into it, but once into it, it can be really rewarding. So that's interesting. And I'm sorry that some of the staff ran out in tears, but hopefully it was short-lived. Does anyone else have any other questions in our audience? Does not look like it. So thanks very much, Sam, for a fascinating talk. Really interesting stuff. Great work all around. And I think I think your talks, your chat about displaced doctors, I think it's really interesting. I really learned a lot about that, so thanks very much. This talk will go up onto the YouTube channel when I have 30 seconds to start editing the videos that I'm already behind with. But if you're watching this on YouTube, I finally got round to it. There are more grand rounds next week, the final grand round of the year, and then into 2026. I'm looking for more speakers, so please do drop me an email or send me a message to volunteer or volunteer someone else to give a talk at grand rounds in 2026. I shall see you next week. And once again, Sam, thank you so much. All right, take care, everyone. Have a good
Thank you
weekend.
very much. Bye.